everyone, and thank you for joining us for today's live stream session, Frequently Asked Questions on Non-BCMA-Targeted Bispecific Antibodies in Multiple Myeloma. I'm Mary DeRome, Senior Director of Medical Communications and Education at the Multiple Myeloma Research Foundation. Today, I'm joined by Dr. Hearn J. Cho from the Icahn School of Medicine at Mount Sinai in New York City. He is also the Chief Medical Officer of the Multiple Myeloma Research Foundation. Also joining us is Ms. Chloe Ray, nurse practitioner from the Icahn School of Medicine at Mount Sinai in New York City, and Ms. Susan Thompson, a myeloma patient from New York City. Patients and caregivers have a lot of questions about these newer non-BCMA targeted bispecific antibodies and their role in the various stages of multiple myeloma management. Our panel is going to answer some of these questions, so let's get started. So I'd like to begin our discussion by first reviewing what is a non-BCMA targeted bispecific antibody. Dr. Cho, can you broadly explain the difference between BCMA targeted antibodies that we may have heard more about and the newer non-BCMA targeted bispecific antibodies that target GPRC5D and FcRH5?
Thanks, Mary. So these are good questions because there's a important role played by the target of the bispecific antibody. So bispecific antibodies at a very broad level are engineered antibodies that bring myeloma cells together with T cells and turn on the T cells. So they're engineered to have two ends. One end sticks to a target on the myeloma cell. The other end sticks to a target on the T cell called CD3, which is one of the on switches for a T cell that activates it to kill a target cell. So BCMA is broadly expressed on myeloma cells. So that's a good target to bring together with the T cells to kill them. But there are alternatives. 5D and FcRH5. So these are two different proteins that are on the surface of myeloma cells, and antibodies that are engineered to stick to those targets, and then have the other end that's engineered to stick to CD3, will bring myeloma cells together with T cells, turn on the T cells, and allow them to kill them.
So, Chloe, is administration of a non-BCMA targeted bispecific antibody largely the same as administration of a BCMA targeted bispecific? And what should patients expect with regards to treatment administration and monitoring, both initially when they first start the therapy and later when they've been on the therapy for a while? How often can they expect to be monitored while receiving this treatment?
So they're administered either subcutaneously or intravenously, like BCMA bispecifics. In the beginning, the monitoring is going to be a bit more rigorous than later on once they've become accustomed to the drug. But they can expect to be admitted to the hospital for at least the first 48 hours, sometimes up to a week, while they receive the initial doses of the drug in what's called a step-up dose. Even the BCMA bispecifics typically have this as well, where you give a baby dose and then you work your way up to the target dose.
Yeah.
So during that time, you still run the risk of cytokine release syndrome and neurotoxicities, just as you would with BCMA bispecifics. So they can expect close monitoring. Once they become accustomed to the drug, they would expect to come weekly, sometimes bi-weekly, and occasionally monthly, depending on how tight their remission is later on.
So, Susan, I understand that you are on talquetamab or Talvey, which is the bispecific that targets GPRC5D, and you've had a stringent complete response, which is great. So can you tell us a little bit about how the treatment process impacted your quality of life with regard to, for example, hospitalization or clinic visits when you first started, and now that you're 5 years out with ongoing monitoring? And boy, if you've been on this bispecific for 5 years, you must have been on like the first trial.
Well, initially when I got the first dose, I was in the hospital for 3 days. I probably had some sort of event because I remember being sedated a bit. Towards the end, by the next day, I just had a headache and they gave me medication for it and I went home. And after that, I came back to the hospital every other week to get
Mhm.
my infusion.
Mhm.
And I've been doing that for most of the time until about 4 months ago, when now I only have to come once a month.
Oh, great. So excellent. So it's great to hear that these therapies are working so well for people. So Dr. Cho, we've had several patients asking about the sequencing of using non-BCMA targeted bispecifics relative to other novel treatments. So can you tell us a little bit about, when during the treatment journey a non-BCMA targeted bispecific would be considered, and whether, for example, they are likely to be effective in a patient who has had prior BCMA directed immunotherapy or CAR T therapy?
That's a good question too. So the two sort of latest and greatest myeloma therapies are CAR T cells, which are engineered T cells that are taken from the patient. An artificial receptor is inserted into them so that they can recognize myeloma cells, and then they're infused back into the patient. And then, of course, bispecifics, which are several of which have been now approved by the FDA.
Mm.
So both of the CAR T cells that are currently approved by the FDA target BCMA. So both of those are BCMA targeted agents. Of the three approved by, two of them are targeting BCMA. That's teclistamab and elranatamab. And happily, talquetamab, which Susan is getting on the clinical trial, was also recently approved, and that one targets GPRC5D.
Mhm.
So when we think about these therapies, the current approval is for patients who've received at least 4 prior lines of therapy. So many of these patients have already gotten the standard, Velcade, Kyprolis, Revlimid, Pomalyst, Darzalex, and other standard therapies. If a patient has previously received either a CAR T cell or a bispecific that targets BCMA and they've progressed, relapses after BCMA targeted therapy sometimes are accompanied by loss of BCMA on the surface of the myeloma cells, or mutations of BCMA that prevents either the artificial receptor or the bispecific antibody from recognizing it, so it doesn't stick to them.
Mhm.
So it makes sense to switch targets in that setting. So if someone has progressed on a BCMA directed therapy, then having an option for either a GPRC5D or an FcRH5 targeted bispecific antibody is a good one.
Mhm. Yeah, that makes sense. So, Susan, talk to us a little bit about, your myeloma journey and what was going on when you started on Talvey. What treatments had you previously been on when you started Talvey?
So I was diagnosed the beginning of 2012. And initially, I was treated with Velcade and Revlimid for several cycles. They were gearing me up for autologous bone transplant, which I
Mhm.
received in 8 months later. And it worked really very well for 3 years. And I also took Revlimid at that same time. After that, my numbers started going up. So I started getting other medications. So I was on Ninlaro, Daratumumab, Ninlaro, Elotuzumab, and I was also on Etizolamide very, very briefly. And also I had to get Velcade again sometime during that
Mhm.
those couple of years. So by then I was out like 6 years after being diagnosed, and they offered me this trial with I always call it GPRC, but now it's a real FDA approved drug.
There you go. A real drug. Wow, that's quite the journey, right? So, that's pretty amazing. So good for you. Oh, okay. So, Dr. Cho, we've been hearing data about treatment responses in relapsed refractory myeloma from fixed duration cevostamab, which is the FcRH H5 bispecific. So can you tell us more about that and what that might mean for patients? Because I think that, for now, most of the bispecifics are basically given to patients until they relapse, but that really wasn't the case with the cevostamab study, at least not the one that we heard about on the recent webinar.
Yeah. So historically, treatments have had to be very consistent and ongoing, because we know that for the most of the medications that were approved for myeloma in the last 10 or 15 years, if we stop treatment, patients would relapse quickly. So that the ongoing treatment was required to keep the disease under control. And when we entered into this new era of T-cell directed therapies with CAR T-cells and bispecifics, the intention, at least with the bispecifics, was to continue treatment, because, as we've known historically, myeloma patients will relapse if we take them off treatment. But interestingly, bispecifics are being used in other diseases, and in a related disease called non-Hodgkin's lymphoma, it has been observed that treatment to patients with lymphoma with a bispecific, and if they go into remission, you can stop treatment and they won't necessarily relapse. So we don't need to do ongoing treatment to keep their disease under control. Now, we did not know that when we were going into the clinical trials for these bispecific agents. So the great success we were seeing with very deep remissions and very long durations of remissions was an important new finding, which then led to the idea that perhaps this is a type of therapy that we can give for a limited amount of time. Patients go into remission. They don't necessarily have to continue the treatment. So this is individually for each of these agents, because they're different. So there are, the early results from the cevostamab trial is very important, because it does give us a hint that perhaps there's a subset of patients who will do well for a long time on a limited duration of treatment. And that means a lot for patients' quality of life. As Susan related, she was coming into clinic every other week to get an infusion. Now she comes once every 4 weeks. Wouldn't it be great if we could give that treatment for X amount of months or a year or whatever, and then if their patients are in remission, we can stop the treatment. And it's an important thing to know. We are in a bit of we were taken by surprise by the great success of these agents, and so we now have to think differently about how we're going to apply these in clinical trials. So we need that data from clinical trials that will tell us it's safe to stop treatment after X amount of treatment. So that's really an important ongoing area of research.
Yeah. So these are things that we really need to have clinical data on before they can be decided, right? So I really did think that was some interesting information that Dr. Suzanne Trudell was talking about cevostamab, because I had not seen that data before when she presented it in the webinar. So it's quite promising, actually. So Chloe, aside from studies looking at fixed duration treatment, how long should patients typically expect to stay on a non-BCMA targeted bispecific therapy?
Yeah, I mean, as Dr. Cho was just saying, we're hoping to, cut it from forever to a finite number of months, hopefully after 12 months. With cevostamab, it's 17 cycles and then they stop.
Yeah, right.
In Ms. Thompson's case, you've been on drug for 5 years and still going strong, but we do still need the data to tell us when it's safe to stop. So patients typically will be on it for as long as they're in remission. If their numbers start to go up or they have side effects that are intolerable, we may take them off or decrease the frequency that they're coming in. So a lot of these patients, even though Talvey is not approved for monthly right now, do go to every 4-week dosing, because they're in such a stringent remission and the side effects were such that they do better at a reduced frequency. So it is still case by case, but hopefully we'll get the data where we can safely give people a year and then take them off.
Yeah. That would be great. Yeah, we'll talk about side
Yeah.
effects in just a minute. But so, Dr. Cho, what do we know about the use of non-BCMA targeted bispecifics in high-risk myeloma patients, such as those that have a 17p deletion or a 414 translocation, both newly diagnosed and relapsed refractory? Has this been well studied? And I don't know. I'm not sure if the non-BCMA bispecifics are they being dosed in trials in newly diagnosed patients already?
So there are a small number of trials that have initiated that are giving bispecifics in very early lines of treatment. So not necessarily with the first treatment, but for example, patients who don't have a great response to a transplant after
Mhm.
induction chemotherapy. There are trials that are putting patients onto a bispecific as a consolidation of the transplant step. So we are moving it and we're hoping to, for example, take advantage of patients' immune systems being more fit. If
Mhm.
they're earlier in treatment, they haven't had a lot of chemotherapy or other types of therapy. So that's an important question that we're investigating now in the field. High risk patients, we know them based on certain features, genetic features of their tumors. So we know that patients, for example, whose tumor has a translocation of 414 or amplification of chromosome 1 or a deletion of chromosome 17, these are patients whose disease tends to behave more aggressively and is somewhat. So, but how do these patients do with immune therapy, which is sort of fundamentally different from chemotherapy? Instead of trying to poison the tumor cells with these toxins that'll kill them and hopefully have relatively few side effects on normal tissue, we're guiding the immune system, the patient's own immune system, to these cells and having the immune system try to eradicate the disease. And it's an important question because about 10 to 20% of patients will have high risk features, and it's important to understand what the role of immune therapy is going to be for them.
Mhm.
So in the clinical trials that have been published, and this is for teclistamab and elranatamab, which are BCMA bispecifics, and with talquetamab, which is the GPRC5D bispecific, there were patients with high risk features that were part. And what they do in these trials, they do something called subset analysis. So they report on the response rates and the duration of responses for all the patients in
Mhm.
the trials, but of certain groups that might be of special interest. For example, patients who are over the age of 75, patients who have renal failure, patients who have high risk features. So in the subset analysis in the published trials, the response rates in the high risk group were similar to the response rate of the overall group. In other words, there was not a statistically significant deviation that it was lower response rates or shorter durations of response. But the caveat is there weren't enough high risk patients to make that finding statistically significant. So
Mhm.
we have early information that suggests that these bispecific agents are just as effective in high risk patients, but we don't know that with statistical certainty. So there are efforts underway to specifically test high risk populations with these new immune therapy agents so that we know for certain whether they're just as good in the high risk patients as they are in standard risk patients. So
Mhm. Mhm.
that's an important question that we are also trying to answer in the field.
Yeah, yeah. Still a lot of questions outstanding, but we'll get to those answers. It just takes time. That's all. So let's switch gears a little bit and talk about side effects a little bit, because there are some side effects seen with the non-BCMA targeted bispecifics that are similar to what we've reviewed previously with the BCMA targeted bispecific, effects like cytokine release syndrome and cytopenias. But we are seeing some adverse events that are unique to some of these newer agents. So, Dr. Cho, can you tell us a little more about the on-target off-tumor effects seen with GPRC5D and FCRH5 bispecifics? We learned recently that some of the more severe skin and nail side effects that are seen with the GPRC5D bispecifics may actually correlate with better treatment efficacy. And has that been your experience as well?
Yeah, that's a good question. So these agents are very powerful because they are targeting proteins and other markers that are expressed on myeloma cells. So they're present on the surface of myeloma cells. Unfortunately, that we don't have targets that are exclusively expressed in myeloma cells. So targets like BCMA, GPRC5D, FCRH5, they're also expressed on other tissues. So there is the risk that the bispecifics will direct immune responses to those because they deplete certain populations of immune cells, so patients are vulnerable to infection. So we know that. In the case of GPRC5D, it's also expressed in epithelial tissue. So this is why we see these effects in the nail beds, on the skin, in the mucous membranes, and this is why it can do things like, cause the nails to become brittle. It can affect taste and salivation. It can affect the sense of smell. So these are side effects that they're on the target, but they're not on the tumor, right? And similarly, FCRH5 may have effects in other types of immune cells, which may predispose for example, inflammatory side effects. So these are important to understand because we need to manage those side effects in order to effectively deliver these therapies. Oh, about the rash. Yeah, yeah, we have seen some correlation between skin and nail side effects with GPRC5D and efficacy. So in other words, patients who show these effects are also showing better responses in the myeloma as well. So it could be that this would be kind of an early indicator of effectiveness. Obviously, we don't want it to become severe, that it interferes with patients' quality of life. But these are important observations, and it makes sense with the biology of these agents in myeloma patients.
Yeah, so it was very interesting on the webinar because Dr. Chari was telling us about this. And then we had a patient on the webinar who was actually on Talby, who was kind of suffering from the side effects, but he felt much better after he found out from Dr. Chari that meant that the drug was working. So I guess that's kind of a good thing. I don't know. So Chloe, there were several questions about patients' loss of their sense of taste with these drugs. So, like, for example, will my sense of taste resume after I stop Talvy? And can it cause issues with my dental health? So what do you tell your patients who are experiencing this, like what they should prepare for?
Yeah. So in the beginning, I think is the most difficult time because they're receiving the drug so frequently. Loss of taste is pretty universal among all the patients that I've seen on Talvy. It does typically improve with reduced frequency or reduced dose if necessary. Whether it's 100% resolved by coming off the therapy is sort of case by case. Certain patients I know have reported, they get monthly dosing, and then for 2 days after their dose, they have a bit of an off taste, and then it goes away completely. So everybody is a bit different that way, but generally with the reduced frequency, they do see improvement. In terms of dental issues, I mean, I think across the board with all chemotherapies, immunotherapies, you're affecting the oral mucosa, you're sort of drying out the mucous membranes, and that puts you at risk for dental issues. So we don't do anything more than encourage oral hydration. Lozenges helps with the taste and keeping everything moist, and then seeing your dentist every 6 months, making sure that your general dental hygiene is up to date. Yeah.
Okay, good. So, Susan, I understand that you had some of these taste issues and also some aches while being on Talvy, but they were worse in the beginning, as Chloe mentioned, and they have subsided some now that you're not being dosed as frequently. So can you tell us a little bit about these side effects and how they may have changed over the 5 years that you've been on this drug?
Well, usually every time I get treatment, I do experience some change in taste for a couple of days. I've noticed that now these last couple of months, it's the time period is shortened. So maybe it's only one day. I say if I get the medication on Friday, then Saturday I have a little taste changes, and then by Sunday it's gone. As far as pain goes, I think every now and then I might get a little headache, but it's really not a big thing. I just get up. Usually it's when I get up in the morning. So I get up, I go downstairs, get something to drink, and then it subsides. So I'm pretty okay. But there is one thing I always tell people. I tell my the people who are caring for me that I do have changes to my hair. My hair is the texture has changed somewhat since I've been getting medication. Yes.
Yeah.
So can you elaborate on that? Like in what way? Has it become more curlier? Is it straighter?
It's more curly. My hair is more curly since I started taking the medication. So I used to wear very short hair. See, Dr. Cho had not seen me in about a year. And he said, "Oh my God, you have long hair." So I let my hair grow so that it's not as, it's not as, the curls aren't as tight. So then when it's longer, it drops down a little bit. But I mean, I make it little curls and stuff like that. So it's curly.
Yeah, that's good. So interesting. Reminds me of when my daughter was very little and her hair was just like straight as a pin. And my grandmother used to just tell me, just cut off all her hair and it'll grow back curly. I'm like, okay, Grandma. So anyway, better to be curlier than straighter, I think. So, okay. So Dr. Cho, again, this year, there was some data on pre-treatment with tocilizumab and its effects on reducing incidence of cytokine release syndrome in relapsed refractory patients receiving cevostamab. And we've seen that now at a couple of different meetings. So what can you tell us about that and what does it mean?
Cytokine release syndrome is one of the most prominent and common side effects of these classes of agents. And they come about because in the initial treatments, when patient has a lot of tumor cells, the wholesale activation of T cells against these tumor cells causes a lot of inflammation, a lot of immune activation. And this can mimic like a very bad infection. So it's called cytokine release syndrome because T cells make a lot of signaling molecules called cytokines, which mediate things like fever, low blood pressure, body aches, confusion, all these hallmarks of the cytokine release syndrome. One of the big cytokines that is involved in this is called IL-6. And tocilizumab is an antibody that sticks to IL-6 and takes it out of mainstay treatments for the management of cytokine release syndrome. And historically, what we do is we would carefully administer the early doses of these agents. If the patient developed fever and other symptoms, we would give them tocilizumab and observe. This is all in the hospital, and we would observe and make sure that they stabilize and don't have any further symptoms. Fortunately, tocilizumab lasts a long time, so it usually rides out the first couple of treatments, and then often because the tumor the number of tumor cells is drastically reduced by those first couple of treatments, we don't see cytokine release with later treatments. But there was a lot of interest in using tocilizumab before the symptoms develop, right? To prevent these symptoms from occurring at all, and maybe ultimately keeping patients out of the hospital. Clinical trials where they are giving tocilizumab a couple of hours before the first treatment to see if that prevents the cytokine release syndrome. And I think that this is important, and we need to understand if that's feasible, because ultimately, again, for quality of life, we want to keep patients out of the hospital. There is another side to that question, though, because there are some theoretical reasons to believe that maybe that first burst of inflammatory activity is important to the long-term effectiveness of these agents. So we need to do this in clinical trials to ensure that giving tocilizumab as a prophylactic, in other words, before the symptoms occur, doesn't interfere with the overall effectiveness of these agents.
Yeah, that makes sense. So Susan, I know that risk of infection is also higher when you're taking these agents. I know that you take precautions to decrease your risk of infection. Then you've been on this drug for 5 years. So can you tell us, what is your methodology for decreasing risk of infection?
Well, I think I've been practicing my decreased risk of infection since I had my bone marrow transplant. So when I go, like say if I go for a pedicure, I don't allow them to cut the cuticles. I try not to go into a big crowd. If I go to a gathering, I try not to let people hug me and so forth. And I also try not to be around very young children because they have a lot of germs.
They do. They do.
Sick.
Very germy, those little kids.
Basically, that's it. I mean, I'm very lucky in the sense that I live in the suburbs right now and I'm retired. So I don't really have to go on like the subway in New York City and get exposed to a lot of people. And that's basically, I think, what I do. Also, I'm very careful about what I eat because if I eat food that is really not, it's been sitting around a long time, I could get some stomach issues. So I try to eat food that's fresh. I don't go into a store if they have those sandwiches that have been sitting there all day long. I don't buy that.
Probably good advice for everyone.
Yeah, right. Wow. That's pretty good.
You got to watch them make that sandwich.
Yeah, watch them make it, and then you can eat it right after that, right? Bring it home. So I would suggest, have you had any issues with like COVID or anything like that? Because you were taking this right through that.
Well, yeah. And no, I didn't have any issues with COVID. Although when I went for treatment, I don't know if it was like this April or something, they told me, the nurse told me my antibodies had gone up. She said I must have been exposed to COVID, but I didn't have any symptoms or anything like that.
Yeah, see, there you go. So, a bunch of us were over in Greece for this big meeting, right? And then, my husband was with me and he got sick and then we flew back and he was still sick. And the minute we got home, because we forgot to bring COVID test with us, we tested and we were both like blazing positive, even though he was sick, but I had no symptoms, not a single thing. Not one thing.
One more issue.
You just never know.
Sorry. One more issue. When I do travel, like for instance, since COVID, I went to Jamaica and then I also went to Europe. When I come back, I do end up with an upper respiratory infection of some sort, but it wasn't COVID either time.
Yeah.
So a lot of our patients will get monthly IVIG. Patients on bispecifics and not on bispecifics, just in the myeloma community, because we know that their immunoglobulins are suppressed by the myeloma and they are at increased risk of infection. So most patients, at least at some point in their myeloma journey, will receive IVIG. But the GPRC5D patients have a lower risk of infection than the BCMA bispecifics generally. So that is one upside of the GPRC, I guess. Yeah.
Okay, so
before we move on, Chloe, what are some of the other prophylactic things that we do for our patients who are getting these immune suppressive agents?
Yeah, so they're all going to be on antiviral to prevent shingles medication. So acyclovir, Valtrex, those sorts of things, they'll be on for indefinitely. With a lot of these immune suppressive agents, we will put them on BJP pneumonia, which is a type of pneumonia, fungal pneumonia prophylaxis. So something like Bactrim or Mepron for the duration of them being on this therapy, in addition to the IVIG.
Yeah. So, I mean, it is an important thing. Very serious side effects from these bispecifics. These infections can be quite serious. So. Okay, so we're going to move on now to our final thoughts. So, Chloe, how have bispecifics, both the BCMA-targeted and the non-BCMA-targeted, affected the outcomes of the patients that you manage? I mean, are things getting better for these patients because we have these great new drugs?
I mean, absolutely. Our enrollment in research trials is down because so many patients are doing well on.
Wow, that's an unanticipated result, right?
I'll be out of a job soon, I guess. But yeah, no, I mean, patients are in sustained remissions for years now. I mean, Darzalex did that too. But this seems, even better. It's very exciting and it's great for the patients because it's not a pill that they have to take. It can be minimized to monthly, the way Ms. Thompson is living her life, and it's extending people's lifespan by who knows how many years.
I know things have really come a long way since I joined the myeloma field in 2014. Back then, there really wasn't that much of anything, but now there's all kinds of things that people can take. Lots of great new drugs. So So, Susan, after your 5 years on this drug, it sounds like you've had a largely positive experience with a favorable outcome and side effects that aren't so horrible. So, it's like really a great story. So, is there anything you want to say to other patients who might be considering this class of treatment and might be concerned about some of these side effects?
Well, I I think it's been great for me. It's not after I got the first dose, my numbers went down tremendously. I haven't had any really bad side effects. I mean, if food tastes a little bit differently, for 1 or 2 days, you just put some hot sauce on it and continue to eat it, And especially if you only have to go like once, like I do now, once a month, you're still able to continue with other activities in the neighborhood and, be around your family and friends. And I think if you can have this medication, then you probably won't have a lot of other side effects and you'll live your life.
Yeah. And one thing to note is that we also do have prophylactic and treatment measurements for the nail and skin and oral toxicities. So starting those up front, like vitamin E oil and, certain heavy moisturizers for the skin, if started from the beginning can be really effective. And like I mentioned, lozenges, keeping your mouth moist. We have we're trying to sort of roll out a ice pack, parotid gland ice pack that they would wear as like a headband around the parotid glands after treatment, which might show some improvements, but is also kind of a commitment from the patient. They have to do it for like 3 hours a day for a period of time. So if you want to try that, you can.
Wow.
But, anecdotally, we've had a few patients that have said that it does reduce their taste changes. Yeah. So that's just sort of on the research side of things. But
that's cool. That's cool.
Yeah.
Okay. So interesting stuff. And so my final question, Dr. Cho. So we've seen a lot of data recently with non-BCMA targeted bispecifics in combination with other treatment regimens. I've even been hearing about trispecific antibodies, right? So what do you think that we can expect from the non-BCMA bispecifics or trispecifics, both in the near future and further down the road?
Well, I think we're very fortunate that we're in an era now where we have effective treatments that are effective even in patients who've had multiple prior treatments, that patients are getting deep remissions and long-lasting remissions with these new treatments. And I fully expect that there will be more approvals for bispecific agents in the very near future, hopefully within the next year or so. The next step is to make them even more effective. So there are a number of clinical trials with bispecifics with other types of treatments for myeloma. I think there's really a lot of interest in combining them with other immune therapy agents so that you can get a complete immune response against the myeloma, the diseased cells. But what we are already seeing is that when we put things all together, we are seeing even greater effectiveness, but we are also seeing more serious side effects. So then we need the next challenge is understanding how to combine bispecifics with other therapies in a way that maximizes their effectiveness, but minimizes those side effects, particularly things like infections, right? And that's one thing we're very conscious of. And I think there's really an ultimate goal to arrive at combinations of therapies that can be delivered for a limited period of time so that patients can have long, durable remissions even after. I'm grateful every day that we have these agents that we are now able to give to patients, even ones who've had all the standard chemotherapy agents. And I think there's new agents coming that may be added to to the armamentarium against myeloma. So as you mentioned, there are trispecific antibodies that are trying to harness other aspects of the immune response against myeloma cells. And so it's a very exciting time to be working in this field, because we can, many of us have hope that we are going to arrive at treatments that will confer long-lasting remissions, ultimately for cures in this disease. So there's reason for optimism. I think that there's a lot of work that still needs to be done, but we do this in collaboration with our patients and our colleagues, and we're, as I said, we are hopeful for the future.
Yeah, good. So, I mean, there's so much on the horizon, and all the meetings that we go to and listen to all the results that are coming out of the clinical trials that are ongoing. It's all very fascinating, and it's all great news. Everything is really working, so much better than just even, 5 or 10 years ago. There's just a lot more out there for patients. So it really is a hopeful time in myeloma, that's for sure. So on behalf of the MRF,
before we start, I want to thank Susan and all the patients who participate in clinical trials. It takes a lot of courage to do this, but it's necessary for us to move the field forward. And I'm incredibly grateful that our patients trust us and work with us on these clinical trials, because we're trying to make better therapy for everybody.
Yeah.
So thank you, Susan.
Thank you, Susan. She's a success story. Yes.
Yeah.
Well, thank you all for taking care of it.
So in addition to thanking Susan, I would also like to thank Dr. Hun Cho and also Chloe Ray for being with us today on our live stream. I'd like to thank everybody who's watching for taking time out of their day. And also I'd like to thank our sponsors, Genentech and Janssen, for their support of this session. So if you have any additional questions about what you may have heard today, please don't hesitate to call our MMRF Patient Navigation Center, and their phone number is 1-888-841-6673. Thank you.